Hello and welcome to today's webinar. My name is Trevor. I'm the Communications Manager for the Canadian Cancer Survivor Network. Thank you everyone for attending today's webinar. This is the last in our fall and winter leg for the 2024 webinar season. If you're new to our webinar series, a little background on our group. CSSN works to connect patients, survivors, and other stakeholder groups with decision makers and the wider community to engage in discussion and to act on evidence-based best practices to alleviate the medical, emotional, financial, and social costs of cancer. To learn more, visit survivornet.ca. This webinar is being recorded and will be available on YouTube, and a link will be provided by the email you registered with, along with a link to the slides provided with this presentation. We will have a quick Q&A session at the end, but if you'd like, please put your questions in the questions tab on the GoToWebinar menu. And now to introduce our presenter. Zeenat Ladak is a research coordinator with the Improving Cancer Care Equity Lab at Women's College Hospital. Within her work, Zeenat applies concepts of health equity and implementation science to improve equitable access to lung cancer screening. Zeenat is also completing her PhD in health equity and pregnancy care at the University of Toronto and is an emerging implementation scientist. And so without any further ado, I would like to head it over to Zeenat for her talk, Trauma and Violence-Informed Care Approaches to Smoking Cessation and Access to Lung Cancer Screening.
Hey, thank you so much. And I believe you are seeing the correct screen. So we will get started. Okay, so hi everyone, my name is Zena. It's great to be here today. I'll just preface by saying that I am not a lung cancer or smoking cessation expert, but I do come with experience in implementation research and evaluation of health services. So trying to understand how to take research and put it into practice and have it last long term so that more people and more places can benefit from the research that we do. And so we have a greater impact. So today I'll start off by just saying that the work that I'll be presenting, it's much more than just me. We have a much larger team, an interdisciplinary team led by Principal Investigator Maureen Sayani, and we have people within our research lab, many patient partners, and our implementation and evaluation committee that has contributed to the work that I'll be presenting on behalf of them today. And so a little bit more about the ICE lab, or the Improving Cancer Care Equity Lab, that's leading this work. We have, as I said, it's an interdisciplinary team, and we are a patient-oriented research lab, and that's what we use with majority of the work that we do. We do use that lens. And our funders for this work as well are CIHR, Ontario Sports Support Unit, and Strategy for Patient-Oriented Research. Okay, so for today, we'll kind of be ending off with trauma and violence-informed care, but I'll be going through a little bit more context leading up to why trauma and violence-informed care is important, and why we need it in the work that we're doing. So go over just briefly lung cancer and income, smoking and income, and then lung cancer screening and health equity, and then going into how to potentially improve equity in lung cancer screening through an e-learning module that we co-created. So what we know about lung cancer incidence and income. So people living with low income tend to have a greater incidence of lung cancer. So you can see on the graph on the left here, the low income, or Q1, known as a region where we have the lowest income quintile. People living with that lowest income tend to have a much greater rate of lung cancer compared to those having a higher income. And if you see on the right here, this is specific to survival rates of lung cancer. So different stages of lung cancer from 1 to 4 here. We still see the same sort of pattern where those with lower income, so that's the blue bar, and then those with higher income, which is the orange bar. So the survival rates of those with lower income are lower overall than those with higher income. So we do see a trend here that those of lower income overall have a greater incidence for lung cancer and a lower survival rate for lung cancer. So there's definitely a connection. And we also see something similar with smoking and income. So here we have a graph that shows people who smoke reportedly daily or occasionally, and those living within the lower income, again, have a higher rate of smoking compared to those living in the higher income. So again, we see a trend here of income and smoking. And so knowing that context of lung cancer and smoking, we know that within the area of lung cancer screening, that baseline health inequities already exist in disease distribution due to social patterning of smoking behaviors. And so another way of saying this is known as the inverse care law, which states that individuals that need it the most are least likely to access and use screening interventions or screening services or programs. So there's a gap there. Those that need it the most aren't able to access it or get it. So there are those inequities because of the social structures in place, for example, like low income. So there is a choice to participate in lung cancer screening, and the choice to participate is complex. And so I'll try my best to kind of explain the context here a little bit of what individuals might go through. So within here, we have pathways of disadvantage, we have lung cancer risk and early detection, and then we have safe spaces of care. So within pathways of disadvantage, these are things that can lead to why someone may or may not decide to take part in lung cancer screening. So for example, working conditions, they might have poor working conditions, comorbidities, they might have other illnesses or health complexities. In addition, their living conditions may not be the best. They could be someone who does not have a stationary home, for example, and it could be their life outlook as well. And then we have lung cancer risk and early detection. So for example, smoking context might be their history of smoking, when they started, what shaped their smoking, and how long they've been smoking. And then we also have smoking cessation, so trying to quit smoking, and then screening perspective, so someone's outlook on their thoughts of why to do screening or why not to do screening. And then we have safe spaces of care, and this essentially includes power, so power between the healthcare provider and the patient in a conversation, for example, as well as influence. So the influence of a provider on an individual, so it could be based on the provider's behavior, how influential they are based on things that they might say, based on if they have a stigmatizing behavior. So these three components, they add up to the complexity of an individual's choice to take part in lung cancer screening. And just an example here with the arrows of how one might be related to the other. So for example, if someone has poor living conditions, based on their priorities of those living conditions, they may or may not decide to take up smoking cessation. Smoking cessation might not be a priority for them at that time. And their living conditions might also, with life outlook, influence screening perspectives. Again, might not be a priority for them. And so they may not want to take on lung cancer screening at their time if they don't see it as an important part of their life. And that might be influenced by a healthcare provider and how a conversation might go with a healthcare provider, how safe they feel in a conversation with a provider, or if they trust that provider, to be able to influence them to maybe change their perspective on lung cancer screening. That's just one example to show that it is complex, the choice of lung cancer screening. It's not just a yes or no answer to take part in. And here I'll go over a little bit about, the gatekeepers to equitable lung cancer screening. And so this is essentially what's involved in having your overall improved health outcomes related to lung cancer screening. So for example, here we have social disadvantage. the largest circle here. And this could include increased health risks that we might want to consider. So for example, housing or income, other social determinants of health that might be influential, or maybe a risky lifestyle behavior. And then we also have lack of resources that might be included in there. So lack of resources to seek care. So for example, needing accommodations to access care, such as flexible work hours, transportation, housing, low income. So those are some resources or lack of resources to seek care. And then we also have the clinical encounter. So that's what actually takes place between the provider and the patient. So for example, within here, we have factors that influence referral to screening. So for example, the amount of time that's allocated within an appointment, whether it's rushed or whether there is enough time for conversation to take place, and for the providers to really have the chance to listen to individuals. Also included in the clinical encounter is the value of team-based care. So holistic approach to care, having multiple types of professionals be involved in the patient's care. So for example, a physician, nurses, and maybe a social worker as well. And then we also have equity-informed healthcare as the third part within this funnel. So equity-informed healthcare could include neglect of structural origin of health risks. So what this means is, maybe there's the choice of smoking, lifestyle behaviors that kind of all come into play related to health risk. And then we have trauma-informed care, which is an approach that centers care based on social needs of patients. It aims to empower patients and aims to enhance social determinants of health for the individual. And we'll go over this a little bit more later when we talk about trauma and violence-informed care. And so all of these three considerations are meant to go towards improving health outcomes. So improving access to care, such as putting things in place to overcome barriers. For example, providing taxi or bus fares for someone to travel to their appointment. And then there's also improving social disadvantages. So trying our best to improve housing and income security to then be able to focus on health. So taking care of some other essential priorities so that someone can then have the chance to focus on other health priorities. So everything that I've kind of mentioned right now provides some context as to the importance of equity in lung cancer screening. And so what we're doing to try to improve equity in lung cancer screening is we co-created an e-learning module, so an educational module to build knowledge and skills in primary care professionals to deliver safe and timely equity-oriented lung cancer screening referrals for people experiencing stigma and discrimination using a trauma and violence-informed care approach. So we've already co-created this module. It includes 4 chapters. It's got videos, interactive activities, notebooks, and other additional resources for learners. It's called Creating Safe Connections, and it's freely available online. And as I said, it's been co-created with people with lived and living experience of lung cancer risk or smoking cessation. And these individuals really drove this work forward. And this module is actually also accredited for 4 professional development hours for family physicians. So a bit of an incentive for physicians to take the module, but it's really open to anyone to be able to learn about a trauma and violence informed care approach, anyone within primary care, any learner, to be able to learn these strategies and take them forward into their work within the healthcare environment. So these are the educators of the module, and I'll be showing you some videos later on, but these are our 4 patient partners that are actually within the module, and other patient partners have contributed to the development of the module. So we have Akila, Marlene, Tara, and Howard. And I will be showing you some videos of these individuals, and it's their ideas to include the videos in these presentations so that they can really be a part of it and part of the experience. And one of our educators here, Marlene, has since passed, but her legacy continues on through the videos in the module, and we'll hear from Marlene in a short clip later on as well. Okay, so we've been talking about why it's important, but what is trauma and violence informed care? So for short, TViC is an approach that considers social and cultural traumas that underpin people's choices. So the reasoning behind why people make the choices that they do. It's an approach that is responsive to the impact of systemic violence on people's choices. And it's an approach that fosters trust and collaboration for strengths-based decision-making. And we'll go into a little bit more detail later with some examples. And why is it important, or why do we need it? TViC promotes high quality, equitable care and improves health outcomes for people. And it's to enable safe and equitable preventative primary care conversations. So these are the 4 pillars of trauma and violence informed care. So the first pillar is understanding trauma, violence, and its impact on people's lives and behaviors. The second one is it creates emotionally, culturally, and physically safe environments for all patients and providers. Third, to foster opportunities for choice, collaboration, and connection. And fourth, to use a strengths-based and capacity-building approach to support patients. And we're going to go into each one of these with an example and a short clip from our educators and patient partners. So the first TViC domain, understanding trauma, violence, and its impact on people's lives and behaviors. I'll play a short clip here from Marlene's experience.
I think I've always been judged ever since my phone knew that I was Native, because I didn't know. And it seemed like everybody was picking on me and fighting with me, and I didn't trust anybody.
So you can really see the impact of Marlene's trauma of not knowing their identity as being Native and how it impacts them. And we also have a perspective from a provider here who said, I think really trying to understand that person, understand the context of their lives, validate the stressors that they are experiencing, and empathizing with the stressors that they are enduring. Our second TViC approach, create emotionally, culturally, and physically safe environments for all patients and providers. And we have an experience here from Howard.
I was looking for help. I was asking for help. I sort of went there on my own validity. I wasn't brought there by the police or anything. I sort of walked in the door because my regular physician made arrangements with the hospital to be there. And I wanted help. I went there for help. But I didn't get help when I was there. It was not what I expected.
So here Howard's really sharing their experience of perhaps not being in a space that was safe, or they didn't feel safe in that space and it was unexpected for them. And an experience from a provider here. But really, really being mindful that when you're first meeting the patient, trying to take that really good social history. Do they have access to housing? What is their financial situation? Do they work? Or do they have family supports? Or do they have case management? So really taking into account the multiple aspects of an individual's life to be able to provide them with that safe environment. The third TViC approach is to foster opportunities for choice, collaboration, and connection, and we'll hear from Howard again for this one.
Because of my doctor and doctors and peer support that I had around me, I cut down on my smoking. Every week I would cut a cigarette off. First week, smoke 20 cigarettes a day. Next week, smoke 19 cigarettes a day. The following week, smoke 18 cigarettes a day. And until it came down to 6 cigarettes a day. And at that point, I had housing. I had 2 or 3 years of serenity. And I had trust in my physician. And my physician approached me and said, Howard, you've stopped smoking. You're down to 6 cigarettes a day. There's a social worker next door that can get you the patch for nothing. And I agreed to it. And I got the patch the following day. And 3 weeks later, I stopped smoking completely. 2 months later, my physician called me and said, as we were sitting in the office, called me and said, Howard, you know, you stopped smoking. You think it might be a good idea to get this free low-dose CT lung scan that's available to people like you that have smoked for many years, that are homeless, living in poverty. It's available to you for free. And you'll find it a short and sweet procedure. And I agreed to it. And I got that lung scan.
I always love hearing Howard's story. I think it's so empowering. So you can really see that they had those opportunities for choice of if they were ready to take on, you know, the next step or not, and it was really up to them. And a perspective from a provider here, providers just kind of go very bluntly, okay, you have to stop smoking, you have to lose weight, and just kind of walk out. That doesn't mean anything. It doesn't go with anything else. Doesn't really go a long way, right? When we're just demanding things, but giving them the opportunities for choice can make it more effective. And the last approach for trauma and violence informed care is to use a strengths-based and capacity building approach to support patients. And we'll hear from Bikila's experience here.
I'm still smoking, but not like before. I smoke maybe 3 days, 20 cigarettes. Yeah, which I found it helps. Not help one cigarette is bad, but from where I was, from how much I've been smoking, it's a good result for me. Even if I'm smoking now, I'm feeling like I can't go more. I can stop one day, but I don't know which day it is. And that's like you're giving hope to yourself. There is a hope. Yeah, just man. One person, you know, has to have a hope, you know, it's in something.
So Bikila sharing their experience here of, you know, meeting their own goals and feeling hopeful to continue based on their own goals and achievements that they feel strengthened about. And a perspective from a provider here says, I do feel like the open-ended questions do help with certain patients, and not interrupting them when they start answering, despite time constraints and whether I know they are going in the direction that will give me some information that I need for their medical issue. I think that's helped in the past year or two, just letting them talk without interruption. So again, going back to having the patients share their experiences in the way that they want to, and providers really listening in. So it's an overview of trauma and violence informed care, and this is the course Creating Safe Connections towards Equity Informed Preventative Care. It's freely available online. The QR code, if you scan it, it will take you to the English version of the course, but we're also working on a French language version right now. And this course, it uses lung cancer screening and smoking cessation as an example. So a lot of the videos that you just saw are in that course as well, and it does go over the context of lung cancer screening. But the learnings from the course are very much applicable to other areas of primary care as well. So this work has been going on for a very long time, well before I started with the group. You know, it started all the way in 2019 where they were exploring different types of possible interventions that they could, that the team wanted to put forward. And then once they decided on a module, there was a co-design process with individuals with lived experience. And so that was with the English module. It was then tested in 2023. And then it's starting to just be fully implemented and evaluated now in Canada, but it's up there and it's available online. And we're also working on the French module. So it was just finished being co-designed this year, the French module. And we're just starting to kind of test it out next year as well. And then the overall hope is that, you know, we will be able to scale this across Canada, have a much greater reach across Canada, and hopefully have this module embedded within certain healthcare practices and services across Canada so that we can scale that trauma and violence informed care approach to more primary care providers and have patients be able to experience the effects of the approach during their healthcare journeys. And again, would like to acknowledge the ICE Lab, CIHR, Ontario Sports Support Unit, and the Strategy for Patient-Oriented Research. And lastly, acknowledging again Marlene, who passed shortly after the module co-design was completed. Acknowledge a message from her to be kind, be compassionate, and to just listen. And that brings us to the end of this presentation. Feel free to reach out to myself or the PI of Maureen Sayani at our email addresses. And happy to take any questions.
Excellent. Thank you so much for that presentation. That was very eye-opening. If anyone has any questions, we can put them in the questions tab on the GoToWebinar menu. So feel free to put any questions there. I was wondering about how much the program is looking to expand in the next couple of years, because a lot of these kind of implementations and all these kind of things are they're very good ideas. Some people would even say that they're more of about a common sense idea, and when it comes to how to look at that lung cancer in this informed way. What kind of plans does your organization have to look into putting this into more kind of established kind of systems within the healthcare system?
Yeah, that's a great question. And in terms of an ideal goal, I don't know yet, but we're starting out. So we're starting out with looking at specific organizations that have a wide reach for primary care providers. So, and for example, we're planning to present at certain specific conferences. So some conferences related to the Canadian Association for Family Physicians. We're also planning to look at specific organizations that have a rural focus, for example. So there's a rural and remote conference that we will hopefully be presenting at. But in addition to conferences, we're trying to embed the module in certain practices. So for example, there's a few clinics that we've reached out to, and we're saying, you know, can you embed this in your onboarding practices so that when you hire on new primary care providers or physicians, nurses, trainees, so even student residents, you know, it's something that they take as they are onboarded into that clinic, for example. So those are a couple ways, and then we're hoping to also kind of sneak into some key important meetings with some high-level people in policy at some point to be able to kind of tell them that the module is important and see other ways that we can embed them. So that's kind of where we're starting out. We're probably going to try and start in Ontario and BC, British Columbia, just to start off. and see how things go, see what practices work out well. For example, maybe presenting at conferences isn't doing much, for example, and then afterwards we'll expand to some more of the provinces and territories in Canada-wide.
Once again, if anyone has any questions, feel free to put it in the questions tab. One thing that I would also ask is, has there been any, say, criticism of this methods? For instance, maybe it's just it'd be too hard to implement or cost cuts. Have you heard about any barriers to putting this in that you've heard from people in the past?
Yeah, I mean, I think with any type of intervention or program that someone's trying to implement, there will be barriers. One of them is the sustainability of the content. So making sure that the content is updated, right? So making sure that we maybe go back 3-5 years down the road, look at the evidence in the literature. Is there anything new to add to the trauma and violence informed approach? So things like that, being able to make sure that what we're teaching is up to date and current. Another thing is sustainability or promotion of the module. So, you know, some of the ways we're trying to get it out there is, for example, putting it into newsletters for certain organizations to send out within their organization. So thinking about, you know, how long do we do that for actively? Ideally, we want this to kind of be running independently on its own, but whether or not that's realistic is definitely something that's a challenge that we have to consider moving forward.
Excellent. All right, that is all the time we have for today. Thank you so much, Zeenat, for that presentation. It's very eye-opening, and it's something that that definitely should be implemented in a lot of other places, because it does definitely inform and educate with that. So thank you very much for that presentation.
Thank you.
All right, so thank you very much to everyone. This is the last webinar that we'll be having for this year, but we are working on next year's CCSN webinar series. So keep in the loop about that by subscribing to our newsletter. If you are not getting our newsletter, check your spam folder, because we do use a third-party email service. And in addition, if you haven't subscribed to our newsletter, you can do so on our website, survivornet.ca. And all the webinars from the 2024 season can be available right here on our website, survivornet.ca/webinar, or on CCSN's YouTube channel. So thank you very much, everyone, for attending, and we'll see you next year.